Okay, I'm a rookie in this field compared to the people before me and the people after me. But I got interested in healthcare because it's obviously a very important sector in the US, but even across the world. In the emerging markets, there's enormous pressure to expand access, to improve quality, and to keep costs down. So in that sense, I think there's a real alignment in terms of our goals across these economies. It's also something that I've been interested in because my general interest is in the topic of innovation in the emerging markets. And I think healthcare is one of those areas in which emerging markets are going to be at the forefront of innovation. When I say that, I don't mean that they're going to be at the forefront of medicine or scientific breakthroughs, but when it comes to delivery of healthcare services, that is using existing medical knowledge to reach the greatest number of people on a consistent basis at a low cost, I think they can provide some very interesting and useful lessons. With that in mind, my co-author Vijay Govindarajan and I spent some time over the last 12 months looking at Indian hospitals. We identified about 40 hospitals that appeared to be doing something innovative. We then zeroed in on 16 of them for in-depth field work. And over the course of the last few months, we visited each one of them. And then identified 9 among them as being particularly good at achieving this combination of quality, low cost. Who's moving this?
It's not automatic, right?
Oh, maybe it's on some kind of timer. Okay. All right. I may have checked my timing and it's probably locked in. So bear with me. So we looked. What I'm going to describe to you is the lessons from looking at 9 of these hospitals that were particularly innovative, and they form the basis of the article appearing in HBR any day. We're waiting for the issue to come out, and the article is titled "Delivering World-Class Healthcare Affordably." Now, if you look at the prices in the Indian context, just focusing on the first 2 columns, for a range of procedures, whether it's something as simple as cataract surgery, or open heart surgery, or getting into more complicated things like cancer treatment, the Indian price is anywhere from 1% to 15% of US prices. Another way of saying it is it's 99% cheaper or 85% cheaper to do it in India than to do it in the US. Now you're probably assuming this must be because the quality is awful. Well, in general, healthcare quality is not very good in India. But in these hospitals, they are providing quality care. And I don't have the time to go into details, but here are some examples of Indian hospitals. Boy, this thing has really got a mind of its own.
Why don't you hurry up?
All right. Yeah, why don't you see? So the 2 hypotheses that first come to mind when you think about low cost in a place like India is it's got to be poor quality. The short answer is no, for at least these hospitals. And the other answer is it must be because salaries are lower in India than they are in the US. And that is true. But even if you adjust salaries and match them to US levels and apply it to the Indian hospital, for instance, this one that does open heart surgery for about $3,160. And that's the price, that's not the cost. Their cost is actually $1,800. And their goal is to bring it down to $800. But even if you adjust the salaries to US levels, it would come to be about 1/5 of US costs. All right, now the question is, how do they do it? And the short answer is there's no silver bullet. It's not as if they do, have some magic formula. They do a lot of things, little things, to constantly lower cost without compromising on quality. And think of it as the Southwest Airlines or the Walmart or the McDonald's approach to providing consistent quality at low cost, or the Toyota model of lean production. In fact, these hospitals, when you ask them, what is your inspiration for doing this? These are the companies they mention. I don't know how many hospitals in the US would mention these companies as their inspiration. But for these guys, this is what is inspiring them to take this approach. 3 elements we focus on initially as explanations for how they're able to do this. The first is that their assets, hospitals that is, are organized in a hub and spoke network. Second is something we call task shifting, which is really a way of relieving doctors from crap so they can do the really important stuff. And the reason why this is really important in the Indian context is there are just not enough doctors, too many patients. And many patients pay out of pocket. On average, in fact, the average Indian pays 70% of healthcare costs out of pocket. Even the poor don't go to government hospitals if they can find a way to go to a private hospital, because government hospitals are terrible. So what we have in India is actually something we don't see in many advanced countries. We actually have a market. Really, healthcare is treated like any other good or service. And because of that, we start to see solutions which we have deviated from because our system is so different from that in these countries. And the third element is something often associated with the emerging markets, and that is frugality. And I'll say a little bit about each of these very quickly. Hub and spoke simply means that in the hub, you put your most expensive equipment, your specialists, and in the spokes, you don't have all the specialists, you don't have as expensive equipment, and it's close to where the patients live. The hubs then specialize in a few things, and they have volume at the hub, and that allows you to improve on quality, because you do a lot of volume, the doctors get better and better at what they do, and it also lowers cost. It's really not rocket science. This is an example of a hospital that has this kind of a 5-tiered structure, starting from the village, going all the way up to the big cities. This is an example of an expert. She's a medical physicist, and what she does is she comes up with treatment plans for people in a cancer network. She's at the hub, but the patient is at the spoke. The treatment is designed at the hub, but it's then administered at the spoke. Now, as a result of the volume that happens in the hubs, these hubs become really pretty good at certain kinds of procedures. And one example here is a heart hospital that is the world leader in terms of volume for open heart surgery for babies, pediatric open heart surgery. They do more than any other hospital in the world. They also do more open heart surgeries than any other hospital in the world. Now, you might be thinking, this is because there are so many people in India, you can't get those kinds of volumes in the US. And no, that's not true. There's actually 6 times as many open heart surgeries done in the US as is done in India. In India, it's done in fewer hospitals. In the US, we have so many hospitals doing them that we don't have any hospitals that quite come up to that level of specialization or volume. So, the point is the hub and spoke, therefore, actually allows you to build skills, allows you to build quality, and allows you to lower costs. For task shifting, I use the example of this eye hospital, famous eye hospital in India called Ardan. And what Ardan does is for every doctor, it has 6 people assisting the doctor in surgery. And I don't know if you can see it in this picture. This is one I actually took through a glass sort of window, and therefore it's not very clear. But there's a swiveling mic device, and the doctor actually keeps switching back and forth between 2 patients. So there are 2 patients in the operating room for the same doctor. One is being prepped while the other is being operated. And while the other is being operated, one is taken out and the next one is brought in, and he just goes back and forth. And really the inspiration was McDonald's. The surgery. They can do cataract surgery for $60. They charge paying patients $100 to $200 depending on what type of lens they want. And this idea of task shifting, freeing the doctor to only do surgery and not do any of the other stuff, and having a lot of support staff so that who are much less expensive and much more available, is part of the secret to these hospitals. The other interesting thing is these women, they're all women who are helping the doctors, are village girls who just finished high school. They're given 2 years of training, and then slowly, starting from admitting patients and so on, they move up to actually assisting doctors in the operating room. So it's very cost effective. They identify with their patients. They live in the communities as their patients. So it achieves so many different things that are positive. Finally, in terms of frugality, they do it on so many different fronts. I just use this one example. This is a hospital. This is actually a tertiary care hospital with 200 beds, costs about $7 million. A lot of innovation here on how to keep the cost, capex down. It's just one example. So it's not a volume story. It's also innovating in every cost dimension to bring the cost down to levels that you would think are unimaginable. And this particular design unit has no air conditioning except in the operating rooms. It has no elevators because it's single story. And in this particular hospital, patients who come in for open heart surgery have to identify 2 family members who have to go through training on how to take care of the patient after surgery, so that 3 days after the patient comes out of the intensive care unit, while they're in the hospital, they've gone through video training developed by Stanford University on how to care for the patient. The same people will then take care of them at home. So it saves money in the hospital, reduces the risk of what happens to them after they go home, and therefore reduces readmission. So saves costs, improves quality. This is the whole point. And all of these examples is there is no real trade-off between cost and quality. Many of the things they do to improve quality reduce cost. Many of the things they do to reduce cost improve quality. Now, can any of this be brought back to the US, in places like the US? We think it can. But we don't attempt, because we don't know the US system very well. We're not saying you can do all of these things. Certainly the conditions in the US are very different. But we're saying, why can't you do some of these things? Can you think about which of these things you can do? Because if you don't do it, this hospital, which is setting up shop, an Indian hospital in the Cayman Islands, and offering tertiary care for about 30 to 40% of US prices, would force you to do